Okay, we'll be looking at the objective testing of the lower quadrant, particularly of the lumbar spine, and naturally we'll start with the observation of the patient. I'd like to introduce to you at this moment the model for this and many of the volumes in this series, Beverly Parrott. Now, Beverly is a therapist in Denver, and I'd like to thank her very much for agreeing to work with me on this. Okay, when we're looking at the patient's stance and the way they stand and their posture, we need to be concerned with obvious deformities and not look for little tiny variations from what is considered the normal, even though that normal is probably abnormal for the majority of the population. So we need to be looking at very obvious changes, and if you can't see it within 2 or 3 seconds of looking, it's probably irrelevant. So, looked at from the back, if we look at the patient's posterior aspect, we're obviously going to be looking for the spinal curvatures, and in this plane we'll be looking at scolioses and rotoscolioses. Can we see a rib hump? Can we see the paravertebrals on one side sticking out? Is it scoliotic? And remembering that all people are scoliotic to some degree or another, is it way off of what we'd expect to be normal? We can look for scars indicating surgery or previous injuries, and we can look for muscle atrophy, difficult to see in the lumbar spine, easier to see in the thoracic. We'll look for hypertonicity in these muscles, suggesting segmental facilitation. Does one muscle just stick out as if somebody stuck a golf ball underneath there? Look for abnormal skin creases. Now, particularly when they're not moving, this would be suggestive of hypermobility or instability, particularly if it's on one side rather than straight away across. Of course, if you've got a very obese patient, then they're going to have creases that mean nothing as far as skeletal function is concerned. Look to see which way their weight shifted. Are they standing more on one leg than the other? Drop a plumb line down the centre and see where it falls in the base of support. If they're leaning towards one leg, it may suggest that that leg is shorter than the other. Look for lateral shifts, the Mackenzie deviation, where the hip is sticking out and they stand like that rather than just a straight scoliosis. We have this shift off to one side. And this is almost always indicative of an active problem, or in some cases it's an active problem that's never been dealt with correctly, and consequently they've adaptively shortened in that position. Look for skin discoloration, and coffee-coloured stains, cafe au lait marks, may indicate a congenital anomaly underlying that stain, which may or may not be significant to the problem that the patient's come in with. Look for hair tufts, particularly in this area, which may indicate spina bifida. Look through the legs, again looking for atrophy, muscle atrophy, where it's more easily spotted. From the front, if we can turn you around, Beverly. Sometimes the lateral deviations are more easily seen from the front than they are from the back. So again, just because you haven't seen them from the back doesn't mean to say it doesn't exist, and you may see it from the front. Otherwise, again, look for the shift in her weight, which again may be easier to see from the front than from the back, looking for a leg length discrepancy. Look for atrophy, particularly in the front of the leg, and you can look to see where the foot is sitting as far as whether it's over-flattened or under-flattened. A little lower down, you would have to pull the front down a little bit, but you could look for low abdominal creases, very low abdominal creases, which would suggest spondylolisthesis. If we turn us sideways, from the side, we can look for obvious kyphoses and lordoses that are way off of the normal. And again, postures vary with body type and with function, and what is considered the normal lordosis, lumbar lordosis, is an average for a particular population. So if you're extrapolating that to your patient, you really need to know which population that patient belongs to. Okay. Now, having observed them, you can do some light palpation through the spine and just run your finger down through the spine, and you're looking for a very local kyphosis. wedging, where the spinous process just juts out from the back, one local one. And this would suggest either an old or a recent crushed fracture of the vertebral body with wedging in front, and it allows this to come back. The other thing you may be able to pick up in weight bearing is a ledge. So as you run your hand down, it stops, and then you have to come out and just follow it down again. And this would suggest a spondylolisthesis.